about cataract, can please step out and enjoy yourself outside. We're going to talk serious business of retinopathy of prematurity. Okay? And I have with me a galaxy of stars who are all specialists in ROP. Dr. Anand Vinekar, Dr. Dogra, Dr. Jalali, Dr. Parijat Chandra, and Dr. Karobi Lahiri, who will enlighten us on the problem of ROP in this country and how to best manage. I'll probably kickstart the process by talking about risk factors, examination techniques, and screening protocols. Because the hall was given to us 15 minutes late, I hope they won't object for us to spill over 15 minutes more. Thank you. So the topic I chose to talk is on risk factors, screening protocols, and examination techniques. Can I request you to close the door, please? Yeah, so before we talk of ROP, we should consider what are the risk factors for premature birth itself, because if that is something you can prevent, you prevent the entire gamut of ROP itself. I understand that that is outside the purview of ophthalmologist's capability, but there are factors which could be potentially controlled. And we, I know, are not directly involved, but have significant vested interest. I sincerely hope that somebody from that specialty will be able to help us in reducing our workload. Coming to ROP itself, there are lots of factors we know of. The major risk factors we all know are gestational age and birth weight, which are standalone factors. In fact, based upon which even all the screening protocols are framed, 1500 grams or 30 weeks of gestation and above. Oxygen, of course, has been identified as an important parameter. A lot of factors have come out in various studies based upon what they call as univariate analysis, which is not important. It's multivariate analysis which is important, which adjusts for other factors. And then you find that most of these factors found on univariate analysis have dropped out. And what was found even on multivariate analysis are certain prenatal factors, perinatal factors, comorbidities, and others. Postnatal weight gain and IGF-1A levels have been promoted as important parameters in the Swedish study. You got patients who are outborn first month of pregnancy nutrition, and specific to AP-ROP were neonatal sepsis and chorioamnionitis. It's impossible for me to go through the details of each one of these factors, but just suffice it to say that in a given situation, there may be more than one factor at play in causing ROP. The recommendations by AIO and AAP for screening, our standard recommendations are infants with a birth weight of less than 1,500 grams or 30 weeks of less gestation period, but anybody with a cardiorespiratory support requirement, even beyond 1,500 grams or 30 weeks of gestation, are eligible for screening. Now, in India, we do find patients who have never had cardiorespiratory support, delivery was in the house or in a village, and yet developing ROP with possibly 2,000 grams birth weight, although the birth weight itself is a question mark. Whether it was really weighed correctly, we do not know. So the recommendations for timing of examination is based upon post-menstrual age more than chronological age. But if you understand that any child who is born beyond 27 weeks of gestation, you follow chronological age of 4 weeks after birth. Below 27 weeks of gestation, you follow the post-menstrual age of 31 weeks. Now, it doesn't harm us if you examine 4 weeks for everybody, so that even if there is a AP-ROP, you will not miss it. So probably it is better to follow the idea of Dr. Subhadra that examine all patients at 4 weeks after birth, irrespective of their chronological age and postmenstrual age. Of course, it does add more numbers to your examination numbers, but I guess it is worth it. Now, there are various models which have been created to help us to identify which is the group which is at risk of developing ROP. They are based mostly on gestational age, birth weight, again, all those parameters which we identified on multivariate analysis to be important. But none of those have really been proved to be so useful that you depend only on that to tell us which case to be screened and which case not to be screened. We still end up examining all children at the age of 4 weeks after birth in most situations. Now coming to examination techniques, I would divide into prenatal preparation, infants preparation, and surgeon's preparation. Prenatal preparation, I would prefer to have the parents wait outside, which I have not been able to enforce in most situations, because the mothers especially, they cannot bear to see the child being examined by you with indentation, with a speculum and all that. And some of the mothers can actually faint just by seeing the examination. And also, it makes it easy for you to teach your fellows or somebody in training to do the examination, because they don't want the same child to be examined by 2-3 people. So they actually object. And brief them, of course, on the need to use a speculum and indentation, because the post-examination you will find the marks seen on the eyelids, that also they're worried about. Little bit of subconjunctival hemorrhage they're worried about. Infants preparation, there's no feed required, should be given 30 minutes before examination, because they can potentially aspirate. Mummy restraint we are aware of. ECG leads are not needed for a routine examination unless the child is in NICU, already the patient is being monitored. Pulse oximetry is optional for an examination. This is mummy restraint, which everybody is aware of, but just to re-emphasize the point that each hand has to be wrapped separately. Both hands are not put simultaneously underneath the blanket. Otherwise, by separately folding it, the child cannot actually bring out the hands, Pupillary dilatation, there are lots of regimens available. A mixture of 2.5% phenylephrine and 1% tropicamide is the most commonly used. In India, we have only the so-called Tropicacil Plus, which when you dilute it, it becomes 2.5% phenylephrine and 0.5% tropicamide, which is okay. A mixture of tetracaine with 1% phenylephrine and 0.5% tropicamide also has been used by one particular group. Cyclopentolate is available in the Western countries made by Alcon, but for some reason is not marketed in this country. 1% phenylephrine with 0.2% cyclopentolate. A micro drop is also been mooted as the best way of dilation, because it is equally effective but safer with no change in the heart rate or BP noted, because the amount of drug that goes through the NLD is very little. A micro drop is just 7 microliters versus 26 microliters of regular drop. Tachycardia is seen with 2 anticholinergic drugs, so you never use cyclopentolate and tropicamide together. You use that with phenylephrine. There are several events reported with dilation, including cardiovascular effects on BP, heart rate, etc. But most of these are not seen when you don't use cyclopentolate, the feed intolerance, ILS, and NEC. But yes, phenylephrine can cause rise in BP and heart rate with 2.5%, but with 1% you don't see the effect. So ideally you should use 1% phenylephrine with maybe 0.5% tropicamide. The preparation of the examiner doing the ROPI examination, full sleeves should be rolled up, no wristwatch, no rings on your finger, no long nails. Because all these can harm the baby and also transmit infection from one baby to the next. Hand scrub before touching the child, make it a routine. The choice of speculum, we got these 4 speculums currently used, of which the Cook speculum has the least trauma to the child, because the amount of spreading of the eyelids is entirely in the control of you, not spring-loaded. Alfonso speculum gives you very quick widening of the eyelids, but can be very traumatic to the child because it really yanks the lids apart. So if it is possible, you have both Cook speculum and Alfonso speculum with you and use it as you require. Follow a set routine. I always start with the right eye, irrespective of which side is accessible to me, so that I remember in which eye I saw what. Because at the end of examining both eyes, you can get confused as to which quadrant is having stage 3 and which eye is having the plus disease. So follow a set routine, finish the entire right eye, start with superior, nasal, inferior, temporal, then go to the left eye and do the same thing all over. Easiest is to start with the temporal periphery, because that's where you're likely to see the disease first. Scan the entire fundus, not just the periphery, because you may miss actually retinoblastoma sitting right in the mid-equatorial region because you're concentrating near the ora serrata. Examine with and without indentation, and examine, The reasons for an inadequate examination are poor pupillary dilatation, a hurried examination because you have to examine a lot of babies and you're in a hurry, unstable systemic status where the child desaturates or is becoming apneic, then you stop examination or you're not able to examine properly. The inexperience of the examiner is perhaps important, because when the pupil is mid-dilated, the extreme periphery or mid-periphery, sometimes they are having difficulty in examining. So there are babies who have been labeled as normal and having actually a serious stage 3+ disease. The complications are apnea. I just take only half a minute. Apnea and desaturation, conjunctival hemorrhages, coronary abrasions are all very, very simple. But sometimes I have seen patients who are having actually a polyp, developing a hemorrhage right in front of your eye. You indent and release. The release process produces a burst of bleeding from an elevated polyp. So when there's obvious polyp, please don't indent. It's not required. Okay? Now there is a stress to the parent. Of course, the missed ROP is the worst complication of examination. Follow up very quickly. 1 week or less, when the disease is very posterior, immature retina in stage 1 or 2, an AP ROP suspect. Follow 1 to 2 weeks, if it's unequivocally regressing ROP in zone 1, but immature retina in posterior zone 2 are a stage 2 disease. And follow up for 2 weeks is for a stage 1 disease in zone 2, immature retina but no ROP, or an unequivocally regressing ROP. And of course, 2 to 3 weeks and beyond is mostly zone 3 disease and beyond. Okay? So when can we stop ROP-oriented examination? Zone 3 vascularization, especially when there was no preceding zone 1 or ROP or zone 2 ROP. That is, the retina is normally getting vascularized. It reaches zone 3, it's unlikely they will ROP. But somebody had ROP in zone 1 or 2, then even when it reaches zone 3, you should be cautious. A full retinal vascularization up to ora serrata, these degrees is mandatory for us to declare the child as normal. Thank you very much for your attention.